Hi, everyone. Welcome to another Rafael Medina subspecialty virtual morning report. My name is Huitin, and today's session will be focusing on HemeOnc. And as always, we have a special guest, expert to the sessions that's going to be teaching us and clinical reasoning throughout the case. So without further ado, I have a doctor. Sam Brondfield. He is our case discussant for today. He is an associate professor of hematology oncology and chief of UCSF Inpatient Oncology Consult Service. He completed medical school, internal medicine residency, chief residency, and oncology fellowship at UCSF. He works as a hospital-based oncologist and clinical educator, attending on the solid tumor consult service as well as the hospital medicine teaching service. He obtained a Master of Arts in Education degree from UC Berkeley. His mission is to educate generalists and trainees in solid oncology. His research focuses on cognitive load and subspecialty training. At UCSF, he is part of the educational leadership team for multiple medical school courses. He greatly enjoys teaching oncology to students, residents, fellows, and practicing physicians. So I think that today we are in for a treat because it looks like Dr. Bromfield love to teach. And of course, the clinical problem solvers will love to learn. So welcome, Dr. Bromfield. And actually just if you want to open the mic and maybe say hello and give us maybe something that you'll enjoy to do beside medicine, because I think life is not always just about medicine. So tell us anything maybe you like to do outside of medicine.
Yeah, thank you so much for that very kind introduction, and nice to see everyone. Um, yeah, I do love teaching and really excited to be here. I think this is maybe the third or fourth one of these I've done, and they're always a lot of fun. And I love how international the crowd is and how kind of interesting and diverse everybody is here. So thank you for attending. Um, and outside of medicine, my main hobby is singing. So I do that a lot. I'm in the gay men's chorus in San Francisco, and we do a lot of like concerts and rehearsals and stuff. I have a rehearsal tonight, and rehearsals are a little tricky to make it to on Monday evenings after a long day at work, but it does keep me grounded. And I agree. I think it's important to have something outside of medicine to keep you sane.
Oh, wow, that's amazing. What type of music do you like to sing?
I grew up singing 90s boy bands like Backstreet Boys. Some of you
My
might
favorite.
Okay, I was gonna say some of you might be too young.
Yep.
Um, but yeah, boy bands and 90s divas like Whitney Houston and Mariah Carey and Celine Dion. Those are my
Oh
favorites.
my, I feel so identified. Yeah, I love the Bastard Boys. It's like, oh my God, we cannot talk about here. But yes, that's my favorite boy band, and of course I know all the songs. So maybe and another time we can just do a karaoke together as well.
Would love that.
So thank you, Dr. Bromfield, to share this with us. And welcome again, of course. We're gonna enjoy hearing of your teaching. I'm sure we're gonna learn a lot on this session as well. So as our case presenter, we have Dr. Constance Wu. She was born and raised in Palo Alto, California, and she attended Pomona College, where she studied chemistry. So after college, she studied biological science abroad at the University of Cambridge before attending to Harvard Medical School. At Harvard, Dr. Wu studied in the health science and technology program and took an additional gap year for research studying melanoma in the Leonard Zone lab. After medical school, Dr. Wu joined the internal medicine residency at UCSF and graduated in 2024. She's currently a chief resident at the San Francisco VA and will be staying at UCSF for Hematology Oncology Fellowship. So congratulations to matching to your the fellowship. And yes, same thing, Dr. Wu. I wanted to ask you, what do you like to do in medicine? And maybe tell us a little bit about your experience when you were studying abroad in the University of Cambridge.
Hi, everyone. Thank you so much for having me. This is my first one, so a little nervous, but very excited. Thank you so much for organizing. I think there are two questions. Things I do for fun. So outside of clinic, I do a lot of art. So I think I was briefly like a little Twitter famous for like maybe a week for some comics that I did, and then it fell off drastically and never again. But it's something that I like to do. And then, yeah, I mean, my study time abroad was a very long time ago. It was a pure research year. So I think it was really nice because I think that was a very international community, got to work with a lot of people. And also I found that the UK had much better work-life balance than I've ever seen before or after, where everyone kind of, we had tea at 10, we had tea at 3, but everyone was still very productive and very harmonious. And so that was something that I tried to take lessons from, but maybe didn't, because then I came back to medical school.
Aw, it sounds like a very nice experience. Hopefully, you can get something similar here as well, because it's true. It's not always about medicine. It's always nice to have something that we enjoy to do. And maybe, I don't know, maybe I have to follow your TikTok and see, because now I'm kind of curious. So thank you both for joining us. Let's see, Jerome, if you're ready, you can deploy the whiteboard. And of course, Constance, if you're ready to start with the case, here we have the whiteboard. And whenever you're ready, Constance, you can start with the case.
Sounds good. So the chief concern for this case was a weakness. And I'll say more like global weakness. And this was a case at the San Francisco VA, I should say, that I took care of. The one-liner for this patient is a 76-year-old veteran, male veteran, with a history of atrial fibrillation, currently on apixaban, left maxillary sinus squamous cell carcinoma almost a decade ago, who had previously received chemotherapy and radiation, but is not currently on anything. GI bleed, status post polypectomy, hypertension, and then Parkinson's disease, currently on Cenemet, who basically came in for weakness times 3 days. The 3 days was kind of like a iffy, like he came in because he really noticed it for 3 days, but if you asked him more, said like maybe he just hasn't been feeling that well for days to weeks, kind of hard to know exact timeline. He said that maybe like a few months ago he was very active, gardening outside and swimming frequently, and then over the last couple months has kind of just gotten slower, less active. And then yesterday was basically like unable to really get out of bed, and so that's why his wife brought him to the ED.
So, Dr. Bromfield, do you feel like this is a good place to stop?
Sure. Yeah.
Okay. So, a question for you, Dr. Bromfield. I know that we are in the session of a HemeOnc, and of course, weakness, fatigue is something that you hear very commonly. So, how would you approach that to differentiate? Because this is a global weakness, but how would you differentiate if this is hematology related, oncology related, or maybe not oncology or hematology at all? How would you differentiate between that or maybe a neurological weakness that can be present in the patient?
Yeah, great question. And weakness is definitely a common concern that folks have. Although I will say, in my experience, most people don't come in saying, I have weakness. They say something different, either like, I'm tired, or, I can't lift my groceries, or, whatever it is. And I feel like often clinicians are the ones who kind of use the word weakness. In my mind, whenever I hear weakness, my first reaction is always like, what actually is going on? And I definitely don't stop there. So I think about kind of systemic causes of weakness versus focal causes. So whenever someone talks about feeling weak, I'll ask them like, are you weak all over? Or is it your legs or one leg or your arms? Just to get a little more specific there. I definitely ask about associated symptoms, thinking about like, are there other neurologic symptoms like cognitive stuff? Are there other muscular symptoms like muscle pain? So thinking about the kind of neuromuscular axis as one possible source for what could be weakness. But then from the HemeOnc standpoint, I'm thinking about other systemic causes, especially someone who's had cancer. People can feel kind of quote unquote weak or tired or sleepy or any number of these sort of systemic ways to feel from, new cancer, progressive cancer, a whole host of hematologic conditions that can alter the blood. Anemia is a common cause of somebody just feeling kind of unwell or weak or tired too. So the differential is super broad, but I usually start thinking about systemic versus focal causes and then drilling down into associated symptoms, just trying to figure out what body system could be at play, or is it a body system at all? Is there some kind of disease process that's affecting the whole body, like cancer or the whole blood? So that's just kind of generally where I start. And you can usually pretty quickly get into some narrower realm than just weakness.
Thank you, Dr. Brondfield. I think that's a great approach because it's true. It's very broad, the differential diagnosis when a patient come in with a weakness. And sometimes it's difficult to ask the correct questions and understand a little bit more. And I think what you just said, make the initial, digging a little bit more about the weakness and when did it start or associated symptoms is very important in to understand the weakness in a patient. So, Constance, would you like to give us a little bit more details about this patient?
Yes. So when you meant weakness, I think, yeah, if you titrate down more, it's probably more like generalized fatigue. There's not like one particular part of him that's more weak than the other. He just noticed that like specific activities are harder for him. Like he used to squat, he used to work in the garden, he used to be able to walk down the hall, and just all these tasks now he just doesn't feel like he's able to do. But it's not like there's one leg or one part of it that's not good. Of note, he does have this diagnosis of Parkinson's, and that was diagnosed 5 years ago. But recently, they did have to up titrate his like Cinemet to try to see if they could do. So he wasn't sure if that had something to do with it. And then also of note, sorry, never mind, not of, also of note. Other symptoms, he didn't have, like, he felt like he was getting lower appetite, some nausea, no vomiting, no weight not loss as far as he knows, and then no fevers, chills, shortness of breath, chest pain, or other symptoms. He just feels like he's just unable to carry out his activities.
So, Dr. Bromfield, do you have any, are you thinking any differential diagnosis at this point, or are you still thinking that this can be very broad?
Yeah, it's definitely sounding like something more systemic rather than something focal, which is helpful just in terms of the fatigue. And fatigue has its own differential. In the HemeOnc world, cancer can certainly cause it, anemia, other blood disorders can cause it. But more broadly speaking, yeah, knowing about somebody's chronic conditions, is this person having a chronic GI bleed? Are they having worsening kind of neurologic or neurocognitive effects related to Parkinson's or drug side effects, like Constance was implying? Even cardiac stuff, people who are chronically in AFib can have a little bit of decreased cardiac output. That can make people feel tired if it's untreated. So there's a lot of possible body systems still involved in contributing to fatigue, but I'm thinking more about some kind of systemic issue rather than like a focal thing affecting, say, arms and legs.
Dr. Bromfield, would you think that maybe with this patient past medical history of squamous cell carcinoma and being treated in the past has anything to do with toxicity, chemotherapy, toxicity related at this point?
Yeah, great question. From the oncologic standpoint, it's always useful to know what stage the cancer was when it was treated and when it was treated to be able to weigh in on that. So Constance might have said it, but I'm not sure if the SCC was localized at the time and treated with chemoradiation. Chemoradiation is usually used for locally advanced squamous cell carcinoma, not so much for metastatic disease unless the radiation was just given palliatively for pain or something. So I'm guessing it wasn't metastatic then. And then I'd want to know when that happened. So fatigue now linking to that could be metastatic recurrence, for example, that can cause fatigue. Um, Depending on how long ago the treatments were. When chemo and radiation are done years ago, pretty unlikely to be contributing to a new presentation of fatigue now, but certainly recent chemotherapy or radiation, fatigue is a really common side effect of those treatments. So depends a little on the timing.
And I can say that it was maxillary sinus squamous cell carcinoma, so I'm not quite sure, but it sounded like it was very localized, but it required like ENT resection. And then he got radiation and cisplatin, but all of this was about 9 years prior to his presentation, so almost a decade ago. And he did have like residual neurological deficits from like the surgery itself, like ptosis and just kind of nerve damage. But other than that, no real deficits from the treatment that, as far as he knew.
That's helpful. And then my only last onc question would be if you happen to know what type of chemo, because some of them do have kind of longer standing side effects that are interesting.
Oh, sorry, cisplatin. I think it was a mono agent. Yeah.
Okay. Yeah, nothing with cisplatin given that long ago that should be contributing to side effects now.
So Dr. Bromfield, a follow question. When you mentioned about the recent compared to maybe a longer time of exposure to the chemotherapy, what would you define as a recent exposure? Is it like a year? We still have to be paying attention to the side effect, or the toxicity, or is it a timeline that you think of?
Yeah, really interesting question. It's totally variable. So lots of chemotherapies can cause fatigue. People also talk about chemo brain. That's a colloquial phrase that a lot of patients will use to describe kind of altered cognition or foggy thinking. And that stuff can last for months. A year is not common, but it wouldn't be crazy to think that someone could still have a little bit of kind of altered cognition or fatigue that long out. Um, but then there's all the kind of idiosyncratic side effects of individual chemotherapy regimens, and some of that stuff can last forever in some cases. So, for example, the neuropathy from cisplatin can be permanent in some cases. There are some cardiotoxicities from some chemos that can be permanent. So it kind of depends on the specific agent. But usually the generalized fatigue, the nausea, foggy brain, that stuff's pretty time limited and it doesn't usually last too long after the chemo is stopped.
Thank you, Dr. Bromfield. I think we're ready to get more, maybe some past medical history from Constance now.
I think I mentioned the big one. So the Parkinson's was diagnosed about 5 years before. The prior squamous cell carcinoma was diagnosed about 10 years before and treated and thought to be in remission. He did have some recent dental extractions, so was getting some like hyperbaric oxygen. But other than that, I think that was the big thing. In terms of, do you want me to keep going for meds and other things?
Yes, go ahead, Constance. Maybe some the social history, anything related at that point before the physical exam, of course.
Got it. So medications, I think the big ones are the apixaban, and then he's also on the Cinemet. Other than that, I think it was fairly normal, hypertension meds. For social history, I think the most notable thing is that this is one of our veterans. He unfortunately had really high levels of Agent Orange exposure, so was previously service connected for his prior cancer. He says that when he was 18, he'd basically like spray it everywhere, and there was no protective gear whatsoever, so got in his nose, mouth, inhaled. Other than that, he used to work at USPS, but now lives with his wife. And up until a few moments before his presentation, felt like he was still fairly active at home. No relevant health-related behavior, no substances, just one drink a week with his wife.
So Dr. Bromfield, would you like to tell us a little bit about if the patient has a lot of exposure to Agent Orange, what type of cancer could be a risk?
Oof. Yeah. So Agent Orange, it's a military grade herbicide that was used back in the Vietnam War to clear vegetation, to clear kind of obstructions on the battlefield, is my understanding. It has been linked with a variety of cancers. Off the top of my head, I confess I don't remember which one specifically it's been linked to and not been linked to. That's something I would have to look up. I don't remember if it's associated with squamous cell carcinoma. But would love to relearn that. I knew it at some point.
I know that was a tough question. Sorry about that.
No, no, I love tough questions, and I'll always tell you if I don't know.
Thank you. We will do the research and we will get back to you for sure. So, Constance, I don't know if you know anything about it that you wanted to add, or do you want to go ahead and say about the physical exam of this patient?
I also don't know off the top of my head what it's like, but I just know that if you've had the exposure, I feel like at the VA, almost any type of cancer you can get service connected for because it's just basically linked to everything and anything. I don't know epidemiology, like what's the most common presentation, but I think when he got the squamous cell of the face, they linked him, regardless of direct or not, to like the government's now considering this was all in the setting of his military service, which was a good thing for the patient. For physical exam, the patient was afebrile. His blood pressure was 145/70. He was not tachycardic. His heart rate was 64. And then he was setting 100% on room air with a normal respiratory rate. On exam, in general, he's tired appearing. He was quite pale, but otherwise no acute distress. For his head and neck, basically had a left-sided facial droop, but per the patient, this was very chronic. He has disconjugate gaze where his eyes, but that's from since his treatment. No lymphadenopathy palpable in the cervical, like subclavicular regions. His neck was supple, no JVD. And then the rest of the exam was fairly benign, I would say. Normal respiratory exam. His heart was irregular, but other than that, no big murmurs, rubs, or gallops. Had full pulses. And then neuro-wise, I would say no rigidity. He did have strength, like 4 out of 5 of his lower extremities, but he basically was just like, I'm too tired, I can't keep them up, rather than like it was hard to figure out if it was true weakness or he just felt like he couldn't do it. His upper extremities were quite strong and normal. I'll stop there.
Sure. Dr. Brownfield, at this point with this, sort of, I don't know if we say like a benign physical exam, are you concerned that there can be an underlying malignancy happening, and if so, why?
Definitely still some concern, just given the history of cancer. Certainly nothing about this presentation so far in terms of the generalized fatigue and non-focal physical exam is sort of screaming cancer, but it's absolutely on the list. I still think we're in a pretty broad place. And when I'm in a kind of really broad kind of general concern like this, I start to think just about like different broad categories of disease that could explain what's going on, especially when there's nothing really focal to direct us so far. So big categories, malignancy for sure with the history, we'll have to prove that with imaging and other workup. Hematologic stuff, as you mentioned, including hematologic malignancy, we'll have to look at labs for that. Other broad categories, infection, I'm glad to see he's afebrile. It doesn't sound like there's other sort of focal signs or other systemic signs of infection to think about, but there are some kind of low-grade chronic infections that can certainly cause fatigue. Autoimmune disease, inflammation can be quite fatiguing for people. So we'll see if anything like that pops out, but nothing on exam suggests inflammation so far. Medication side effects we've kind of already talked about. And then endocrinopathies as well. One thing with kind of head and neck region stuff is just thinking about thyroid, especially people who have received radiation to the head and neck. With a maxillary sinus, I'm not sure how much the thyroid may have been in the radiation field, but just thinking about hypothyroidism as another cause of fatigue. So you can just see I'm starting to kind of fall back on like broad categories of disease, and I'll definitely want some labs and imaging to help investigate further. And just to say also, like, there's a lot of reasons people can get tired. This person's 76 years old. And many people coming in with this general concern, the workup may not reveal much. In this case, because we're in a CPS report, I'm guessing it will, but just to kind of realize that this workup may not always show something.
Yeah, I think Dr. Brownfield, you brought a very good point when it comes to patient, like elderly patient, they don't show up all the symptoms as a younger patient. Sometimes even if the patient have the infection, doesn't really scream for infection. So that's something to take under consideration. So I think, Constant, you can give us some labs and see if there's anything that it will be worrisome and maybe something that is going to help us to get closer to some differential diagnosis for Dr. Bromfield. So go ahead.
Yeah. So the CBC, his white blood cell count was 1.81. And I should say he had normal PCP fault labs 4 months prior, and it had been 8.5. His hemoglobin was 9.1, and again, this was down from 12.4 about 4 months ago. And then his platelets were 111, down from 140 4 months prior. For his BMP, everything was largely within normal limits. I won't list it all out, but he had like chronic CKD, a creatinine of 1.21, but not too significant. And then they did get a TSH that was within normal limits, and his prior one had been within normal limits like a year ago. And I'll stop there with the labs. We got more later. But.
Dr. Brondfield, would you like to get more information, or would you like to talk about maybe the pancytopenia in this
Yeah.
patient?
We can talk about that briefly here before we get some more info. So yeah, some striking CBC abnormalities that are certainly not within the range of normal or aging. So a couple quick things. So pancytopenia technically is anemia, thrombocytopenia, and neutropenia, not just leukopenia. So we'll definitely want a differential on that white blood cell count to see whether all the white blood cells are down or whether it's neutropenia or lymphocytopenia. And then, yeah, with the anemia, for sure, MCV, retic count, and smear are a great kind of first pass workup for anemia, and the smear particularly for pancytopenia, very helpful. So I think that's probably how I would start here, is just getting a little more information on that CBC, just to kind of know what we're dealing with here. And then the time course of it, I'm so sorry. I know you said already how long it's been since the labs were normal. I would just want to make sure I knew that, because acute pancytopenia is pretty different from a slowly drifting down blood counts.
Dr. Bromfield, actually, if you wanted to expand a little bit more, how would you approach to pancytopenia? I think that is a very hot topic for any resident or intern. So we'd like to know, how would you approach when you see a patient with pancytopenia?
Yeah, so diagnosing pancytopenia is important because it's different than a single cell line being down, which has a kind of broader differential for where that comes from. Generally speaking, pancytopenia, when all the cell lines are down, is typically from the bone marrow and is a cell line production issue, and that has its own differential. It's possible to get pancytopenia from other sources, often from multiple causes at once, like if someone has DIC plus like some marrow suppression or some medication effect or something like that. But usually if it's a unifying cause, it's going to be in the bone marrow. And then the question is, do you need a bone marrow biopsy, or can you diagnose what's going on without one? Bone marrow biopsies are invasive, but certainly not the most invasive thing you can do. So we have a pretty low threshold for doing a bone marrow biopsy in somebody with pancytopenia, but usually peripheral blood smear first, because sometimes that gets you to the diagnosis. And then the broad differential for pancytopenia, sort of similar big camps of disease we've been talking about. Malignancy is high on the differential, especially for an older person. And it can be hematologic malignancy like leukemia. It can be a metastatic solid tumor to the bone marrow, which prostate cancer and other cancers can do. Infections can invade the bone marrow or just cause suppression of the cell lines, even without invading the marrow. So a variety of infections are on the differential. Inflammation can cause cytopenias, usually not so much leukopenia or thrombocytopenia. Usually it's anemia with leukocytosis and thrombocytosis. So a little bit less likely there. And then there's some other kind of hematologic disorders that can do it, like severe B12 deficiency can cause pancytopenia. So differential is still pretty broad. Medications can suppress the bone marrow. So yeah, more workup needed, but that's my general approach. And just diagnostically, it's all about, can a first pass of non-invasive workup get you there, or do you need a bone marrow biopsy for diagnosis?
Thank you, Dr. Bromfield. Constance, you can give us more details.
So I can't remember the exact differential, but I think the white blood cell count, that it was technically not neutropenia. I remember that it was like, I think above 1.3. The neutrophils were 1.3 and above, and so not technically neutropenia. He got a blood smear that showed pancytopenia in terms of like sparsity, and then they saw ovalocytes and teardrop cells. There were no blasts and no atypical cells on the peripheral smear. For reticulocyte count, I don't remember the exact number, but it was inappropriately low to normal for his hemoglobin. He did get a vitamin B12 that was normal. Someone put a copper in that was normal, and LDH was normal. And then he got UA with some proteinuria. On others, they did a review of records, and for reasons that I won't get into, basically there was some separate problem that didn't end up being related, that he got a lot of labs. So he was HIV, HBV, HCV negative. A lot of infectious studies were done then. SPEP was normal. And then they did find that there was this question of cirrhosis in a prior CT abdomen pelvis. So he did get a right upper quadrant ultrasound to look at that to see for any causes. And at that point, hematology oncology was consulted for consideration of bone marrow biopsy. And I can keep going. Do you want me?
So I think we could stop here for a moment. I would like to ask Dr. Bromfield, when you see this blood smear, and you mentioned that it's just something that we need to, go ahead and do the bone marrow biopsy. At this point with the blood smear, how would you interpret what we see in here, and what condition can we associate with, and why at this point you want to get the bone marrow biopsy?
Yes, definitely. So the blood smear, the two findings are ovallocytes and teardrop cells. Ovallocytes are fairly nonspecific. You can see them in iron deficiency anemia and a variety of other causes. The teardrop cells, mechanistically, that is usually red blood cells getting kind of forcibly pushed out of the bone marrow by something in the bone marrow. So when I see that, I'm thinking it's likely there's something happening within the bone marrow, and it makes me more likely to want to do a bone marrow biopsy. What it is in the bone marrow, we don't know yet. It could be a primary hematologic malignancy like myelofibrosis, I see suggested in the chat. It could be a metastatic solid tumor like metastatic prostate cancer, or even metastatic squamous cell cancer from the prior maxillary sinus malignancy. Head and neck cancers can invade the bone marrow too. And it doesn't have to be malignancy doing it. There could be other sort of infiltrative diseases that are non-malignant in the marrow that could give you teardrop cells as well. Another thing that's suggestive of a process in the marrow is a left shift in the white blood cells. So seeing like more bands or more immature whites. I didn't hear about that on the differential, but just another piece to look at. And we're not seeing frank blasts on the smear, so that makes acute leukemia less likely, but not impossible. You can have leukemia that's totally restricted to the marrow and not releasing a lot of blasts into the peripheral blood. So yeah, all this telling me we are likely to want a bone marrow biopsy. I'm glad that HemeOnc was consulted, and that may help us get at a diagnosis going forward. And then, yeah, I agree with the chat. I'd want to know the MCV on the anemia. The retic count being inappropriately low is, again, further suggestive that this is a production issue and localizing toward the bone marrow.
Okay, the MCV was, I think, within normal range. It was not macrocytic or microcytic.
Okay, that's helpful. Yeah, macrocytic MCV may be more suggestive of myelofibrosis, but you can get that with a normocytic MCV as well. So it doesn't help us one way or the other that it's normal, and we'll still need more data.
Great. So the inpatient team agreed with you, and so they were concerning for the some bone marrow process, so they decided to get a bone marrow biopsy. And then the other thing they were thinking of in general was just that there was a possibility that Cinemet could cause bone marrow suppression, but they agreed that it was less likely given the chronicity of the patient and the acuity of the drop. So he got a bone marrow biopsy. Per the procedure list, it was very difficult. And so when they sent it off, they saw that it was POSI or aspicular. And it did send flow cytometry, but they still sent it. And then they were like, maybe this won't actually be that helpful. And then there was a discussion about whether or not to discharge the patient for follow-up while awaiting these results.
That's actually an interesting question, Dr. Bromfield. So with this patient, to at this point, would you discharge the patient, or do you want to admit the patient? How would be your management? It's going to be an inpatient or outpatient for him?
Yeah, good question. And I'll come to that in just one second because the bone marrow biopsy, I think, figures into that a little. So there's generally two reasons why a bone marrow biopsy wouldn't really yield much. One is that you missed the marrow, and that happens for sure. And another is that it's a quote unquote dry tap. meaning that you got into the marrow space, but when you aspirated and pulled back, there was no component to grab. You can have a dry tap from myelofibrosis if there's a lot of scarring in the marrow. You don't usually get a dry tap if you're in the marrow space from most of the other causes we've talked about. You can also get a dry tap from a kind of fibrotic progression of some myeloproliferative diseases as well in the marrow. But yeah, myelofibrosis, especially in a 76-year-old, would be a more common cause of that epidemiologically. So inpatient versus outpatient, I think the acute concerning stuff would be, is there actually acute leukemia in there and we just missed the marrow somehow? Otherwise, with kind of weakness, my main concern is, will this person be okay at home? Like, can they actually be safe at home? Are they going to fall? Or is something acutely going to get worse at home from what we're seeing? It sounds like the cell counts, as far as we know, haven't dropped super fast. But if we only have one data point 4 months ago and one data point now, I don't know what the counts are going to be tomorrow. And I don't know when the drop started. So I at least want to be trending the CBC one more time just to make sure that it's not acutely falling. There's no acute bleed that we've missed. But yeah, so I'm not sure, based on all the information we have right now, whether this person would be okay to go home. I'd want to do that comprehensive assessment to figure out the safety of that discharge and also know what the follow-up is going to be. But nothing that's come out so far has said to me this management is definitely going to be inpatient, but we'll see.
Great. So to answer your question, I think what they told me, because I was a senior on team, so I was primary medicine, and what they told me was that when they tried to do the bone marrow biopsy, it was like sinking sand. So just like they were able to get in, but they weren't able to like grab anything. And so when they grabbed, it came out. It was, I don't know if that's what you mean by dry tap, but that's how they described it to me.
Interesting. Yeah, like if the bones are really soft, that can be a reason why the needle just kind of slips around. That's most often multiple myeloma causing really soft bones, but there are other possible reasons too. And multiple myeloma, pancytopenia is not that common with it because myeloma doesn't tend to like diffusely invade the marrow so much that you get a ton of cytopenias. But again, possible. So yeah, I'm not sure what's going on in the bone marrow, and that description doesn't help me come to a specific diagnosis personally, but maybe others do know what's going on from what's been said so far.
And then basically we had the same question. I think the inpatient team had been pretty comfortable. We did check CBC a few times and they were stable. And so they thought that maybe this patient could go home and just follow up in clinic within like 1 week. So very like soon follow up. But then the patient and the wife actually felt like not good going home. They said, I just think he'll fall and he'll get worse. So they asked to stay. And then over the weekend, so we basically kept him over a weekend just to see how he might do with PT. And then during that time, his white blood cell count just kept going down. So I think it dropped from 1.8, I think, to 1.3 or 1.2 over the weekend. ANC still above 750, but steadily dropping.
Yeah, so interesting. And no changes on any of the other hematologic tests like peripheral blood smear or anything like that.
No. And then maybe I'll stop there. I don't know. Anything has more questions? I can keep going with some of the results.
Yeah, you can keep going. Actually, I think the only thing I was going to ask to Dr. Bromfield is, what point do we consider to do another bone marrow biopsy? Do we need to do at this point, or do we wait? Because I know that it was unconclusive, so I don't know what point we can repeat a bone marrow biopsy.
Yeah, one piece that I think is missing from this kind of otherwise not super revealing workup would be some imaging. And that may help to answer that question about whether a repeat bone marrow biopsy is reasonable to do. My guess is probably some CT scans would have been done before the first bone marrow biopsy was done, but I might be wrong about that. And if there was no imaging done before this point, I would get some now, starting with just CT chest, abdomen, pelvis to see if there's any other lesions other than the bone marrow that might be amenable to biopsy to figure out what's going on. If the CT scan was normal, or if it showed some like possible lymph nodes or something, a PET CT would be reasonable at this point, given the hematologic abnormalities, to see if there's any lymphadenopathy that might be worth going after. So I'd want some imaging next before I repeat a bone marrow biopsy.
Yes. So basically, very shortly during the weekend, as things were dropping, basically the lab called back and was like, the bone marrow biopsy is definitely non-diagnostic. And then the same time, the flow came back and said that there was some concern for an abnormal cell population concerning for CD5 negative, CD10 negative B cell lymphoproliferative disorder. And so at that point, we decided to keep him. And I think he already had the CT. I didn't write it down, but he did get a PET CT right after that finding just to look for anything. And his PET CT was actually all negative. Keep going. So then basically, I think the big problem was like, how do you get a better bone marrow biopsy? You have to repeat it.
Dr. Brondfield, would you like to explain to us what does it mean, the flow cytometry? What does it mean, the CD5 negative, CD10 negative B cell lymphoproliferative disorder? Can you explain a little bit?
Yeah, and to be honest, I have not memorized a lot of these markers. Lymphoproliferative disorders are disorders of lymphocytes that are proliferating and are generally mature. CLL is the most common lymphoproliferative disorder of B cells. CLL cells aren't technically B cells, but they fit sort of under B cell lymphoproliferative disorders. Um, I I don't recall if CD5 negative, CT10 negative gets you to CLL. I don't know if Constance might have brought that information, but yeah, I'm still worried about a hematologic problem and wondering if this lymphoproliferative disorder is primary or just along for the ride. Because, for example, CLL is commonly diagnosed in folks and may not be responsible for their presentation. It's pretty common in 76-year-olds. So that's the question I'm left with is this the cause, or is this just kind of a bystander effect? And if another bone marrow biopsy that is diagnostic is feasible, that's where I would go next with a negative PET CT.
Thank you, Dr. Brondfield. Constance, do you have more data that you can share with us?
Yes. So I think the idea, I don't think it was, oh, I should know, but I don't think it was pathognomonic for CLL. But the inpatient team felt similar that they weren't quite sure what to make of this B cell population. Like it's weird, but it didn't, especially with the negative PET CT, they didn't know what to do. And so skipping over, it basically took a week to get this person over to a different VA to get a CT guided bone marrow biopsy because the San Francisco one doesn't have an attending here who can do it. But and in the meantime, his cell counts kept dropping. But he did go on Christmas Day, 2024, and get a bone marrow biopsy at the Palo Alto VA. And at that time in the evening, the pathologist at Stanford called me and said that they were concerned for an acute leukemia.
Yeah, really important that the inpatient team pursued that second bone marrow biopsy, because if that ends up being the diagnosis, acute leukemia, you can imagine that this could have easily been missed if you stopped at the first bone marrow biopsy being negative, but you let the progressive pancytopenia, guide you to doing this again, which was, I think, really crucial. And so the acute leukemia that's postulated could be an acute myeloid leukemia, could be an acute lymphocytic leukemia. It's possible the flow is more consistent with an acute lymphocytic leukemia, but usually B cell lymphoproliferative disorders are mature. So I'm not sure whether this will be myeloid or lymphocytic, but sounds like they'll do some flow cytometry on those cells on the marrow to try to identify what type of leukemia this is.
Yes. And in the daytime, a day later, they said that actually the flow supported APML with stat fish pending.
Yeah. And one teaching point is there's really no great way other than flow to tell the difference between acute myeloid versus acute lymphocytic leukemia. You can see blasts on the smear, blasts on the bone marrow biopsy, and you still don't know till they do the flow. And the treatment is different because the chemotherapy regimens have different effects on these different entities. So it is really important to distinguish. And we can talk as much as you all want about APML because that's a pretty special case that requires some additional thought and management initially. So great job with the diagnosis and getting there.
So Dr. Brondfield, so now we have the diagnosis. Can you tell us some of the key features that we can see with APML and that help us to kind of go to the diagnosis, maybe some key features that you can share with us?
Sure. Yeah, so APML stands for acute promyelocytic leukemia. It is a particularly dangerous type of acute leukemia and a particularly treatable kind. So if there's two kind of features of APML to remember, distinguishing it from other types of leukemias, it's the most commonly associated with DIC and can result in fatal brain bleeds pretty quickly after diagnosis or before diagnosis. So this is really important to pick up as quickly as possible and to treat supportively any evidence of DIC to prevent bleeding with appropriate transfusions. And then the second thing to know is that APML is unique in its ability to be susceptible to targeted therapy. So the characteristic translocation for APML is the PML-RAR alpha translocation, and that is targetable with a medication that can be given pretty quickly in the hospital. And I would guess most hospitals carry medications to target PML-RAR alpha. I could imagine there might be some less well-resourced hospitals that don't. So it would be key to get that person to a hospital where this medication exists. So yeah, it's called ATRA. It's just a derivative of vitamin A, and it can cause really rapid responses in APML. And someone in the chat spelled it out, ATRA, all-trans retinoic acid. So it's not a chemo. It's just a derivative of vitamin A, so it comes from a pretty benign substance. Not that it's a totally benign medication, but it can help really quickly. The problem with it is that it causes rapid differentiation of the leukemic cells, and there's a whole differentiation syndrome that can result that can actually in itself be dangerous. So the take home is diagnosis and treat it as quickly as possible to avoid bad outcomes, and monitor closely during treatment, because people can get this kind of rapid systemic inflammation sort of thing going on. Those are the things I would remember about APML. It's a pretty unique condition.
Thank you, Dr. Brondfield. So for the patient, were you surprised that this is the diagnosis, or do you have any clues like along the case that this could be APML?
There's nothing along the case that specifically told me this was going to be APML. I should have asked for the coags and didn't when acute leukemia was on the differential, because that could clue you into the presence of DIC, which would then coags and fibrinogen, which would then make APML more likely than other types of leukemia. But the real clues here were the cytopenias, the fact that all the cell lines were down, which really localized to the bone marrow as the most likely place for a problem to be. The smear showing the teardrop cells, which were concerning for acute leukemia. The absence of blasts on the peripheral smear not being reassuring, knowing that you can have acute leukemia in the marrow without any blasts in the peripheral blood, just because they're not making it out into the circulation. So those are really the only things that kind of clued me in. And it wasn't until we successfully got a bone marrow biopsy and went and did flow on it that we would have been able to come to this diagnosis.
Thank you, Dr. Bromfield. So I think we got a couple of very important teaching point about this case. But now I want to hear about Constance. How do you feel about taking care of this patient, and what do you learn from this case?
I think we were all surprised, and it was a very interesting experience. I think seeing some of the chats, yeah, I think APML, I think in some ways this patient had very lucky presentation where he actually didn't have DIC that we could tell, didn't have any bleeding, had nothing on smear. And so it was, causing his pancytopenia, but otherwise, besides the profound fatigue, never really had any symptoms or signs of end organ damage. I would say it was very humbling just trying to navigate systems wise, because I was at San Francisco VA, he went to the Palo Alto VA, and then we started him on the all-trans retinoic acid immediately, but the VA didn't have arsenic. So then the question is, how do you get people the treatment? And so he actually went to UCSF and had, I think, about a month of inpatient stay just to get treatment and induction, kind of heavier cycles of treatment. And I will say overall, this meant a lot, because I think for this patient, it was just really hard too, just not knowing, and then knowing he has something very severe, but also curable, but also it's still a very long treatment regardless. And this patient, just to kind of close out his case, he went to UCSF, he got his induction treatment. Then he unfortunately was 2 weeks, so had to really be inpatient or in the VA kind of like community long care center, where basically it's like a sniff and come back and forth. And so he is still here. It's been now, it wasn't December 2024, it was December 2023. So he's been here now for almost 16 months, 15, 16 months inpatient. He finished his treatment, he's in remission, but just is still too weak to leave. On maintenance treatment, his blood count's still dropping. So I think despite in some ways this being a very curable disease, it's also a sign that like people still have to go through a lot. But the patient's very strong, and he's doing it all for his wife, because he otherwise is not that interested in prolonging his life, but he just really doesn't want to give up for his wife.
Thank you, Constance, for sharing that experience with us. And I think one last question for Dr. Brondfield here in the chat. So here says how common we do not see blast in an acute leukemia.
I'm guessing the question is, how often are there no blasts on peripheral blood smear? Because the diagnostic criteria for acute leukemia is you have to have 20% blasts either in the peripheral blood or in the bone marrow on biopsy. So you could have 0% in the peripheral blood, but still have 20% in the bone marrow, and that would count. I don't know numbers in terms of how frequent it would be to have a normal blood smear or a smear without blasts and have acute leukemia in the bone marrow. My anecdotal sense is that it's probably more common to diagnose acute leukemia with blasts on the blood smear than having no blasts, but I don't have data off the top of my head to back that up. So I'd have to look that up. But yeah, I've certainly seen cases anecdotally of acute leukemia with no blasts on the smear, and then the bone marrow is really revealing. So I think a great teaching point and learning point for me during my training was if you suspect acute leukemia from other features of the case, don't let a peripheral blood smear without blasts reassure you that that's not what's going on.
Thank you, Dr. Bromfield. So we have reached the end of the session, and thank you so much again for this amazing session, Dr. Bromfield. And I'm sure that we all learn from a teaching point. I love the way how you reason throughout the case and give us all the teaching points one by one. And of course, Constance, thank you so much for writing up this case and bringing it to us so we can all learn from it. So thank you again, everyone, for joining today, and we will see you on the next episode of Subspecialty Virtual Morning Report. Bye.
Thank you all.
Thanks so much for having me. That was fun. Great job.